Thanks, Sabrina. Hi, everyone. I'm Matt Somerville from the IOE's Department of Psychology and Human Development, and I'll be chairing a session today. It's nice to see so many familiar faces there. So today's session is the final Catalyst seminar of the academic year, and our theme, as Sabrina mentioned, is implementation science. So trying to better understand how we can move evidence-based practice into routine, everyday practice. We have two really interesting talks for you today. One's focused on everyday education settings, and the other focused on clinical and community settings. So the plan is to run both talks back to back, and we'll take questions at the end. So I'll briefly introduce each speaker. They'll speak for about 20 minutes, so that will leave us plenty of time for question and discussion at the end. So our first speaker is Dr. Amy Harrison. Amy is an associate professor in the Department of Psychology and Human Development and a clinical psychologist. Amy also leads our department's Evidence to Action Hub and an Implementation Science Initiative. So Amy's research examines the cognitive and social emotional factors that maintain eating disorders, and she explores how these insights can be used to develop novel treatment adjuncts for people with the most severe and complex forms of eating disorder. Today, she's going to talk to us about implementing mental health research across clinical and community settings. So over to you, Amy.
Well, thank you so much. Thanks for having me, and thanks for the lovely introduction. Let me just share my slides. Okay, I think that's working.
Yep.
So as my colleague Matt mentioned, I'm going to be thinking with you today about my learning around how I've used my research to implement some change in clinical and to some degree community settings. So welcome. Thanks so much for joining today, and I really look forward to discussing these areas with you. So in this short talk, I'm planning to use two examples from my research work around implementing research in NHS and community contexts. Um, Having worked as a clinical psychologist in the NHS and then come to work at UCL, I'm really fortunate because I've got a good network of colleagues and services that I've got to know over the years that I've been able to utilize to really help me in this journey. I'm going to use each example to illustrate my learning and share that with you around some of the barriers and opportunities that I've encountered along the way. And I really hope this will allow us to discuss a really pertinent question in the field at the moment, which is how can we actually go about designing research and implementing practice change so that it really promptly reaches the people who need it most? So, just to orientate us to kind of the task at hand, eating disorders is the area that I work in, and we know that this is a psychological disorder that's on the rise in young people, and children and young people are the age group with the kind of it's the most common age of onset. Um, Eating disorders aren't a sort of diet gone wrong. They are serious mental health difficulties and they have significant physical health consequences that can sometimes be long lasting. Eating disorders are very heterogeneous in nature, so they involve a really wide range of behaviors. So that might be restricting dietary intake, excessively exercising, binging, purging, and many other behaviors alongside. Aside from the behaviors, we know that these eating disorders really have a significant impact on people's emotional experience and their daily life functioning. And because of this, they lead to high levels of morbidity, and they are also associated with the highest mortality rates of any psychiatric illness. And they typically, it's not the exception, it's the norm, go with high comorbidity, not only psychological disorders, but also physical health conditions as well. They impact people's social emotional functioning, and this is a factor that also maintains the illness, and they lead to under and unemployment and delayed and disrupted milestones. We do know that people can recover from these awful illnesses, but in many cases, there's a kind of waxing and waning course. So I think the principle that's guided my research has really been working with people with lived experience to understand more from their points of view and their significant personal experience and expertise, how to go about implementing change in a way that is relevant and accessible to them. So, the first example I'd like to share with you from my own work is a project that I've led the psychology work stream on called Steady. And Steady has tried to develop a psychological intervention for people living with something that we're calling TIDE. And TIDE is type 1 diabetes and eating disorders. And this was designed to be a 12 session individual outpatient intervention drawing on an evidence-based approach in eating disorders, CBT, and bringing that together with diabetes education to try and address diabetes self-care and disordered eating outcomes in people living with TIDE. And we were hoping to do that safely, and that meant we didn't want to deteriorate people's glycemic control. So, how did we go about doing this? Well, I think a pathway to implementation science, evidence to action, and action to evidence, because it can go both ways, is really to work with people with significant lived experience. So, we were able to work across a series of workshops with people living with type 1 diabetes, with disordered eating. And people at various stages of their eating disorder journey. So some people had recovered, some people were actively unwell, and we also had groups of people that had never experienced disordered eating because we were interested in some of the protective factors in this group. And through these workshops, we co-designed a treatment toolkit. And we quickly realized early on that this wasn't going to be about adapting treatment manuals. This needed to be much more bespoke. Um, and I think that's a really quick win in this kind of work that once you get to talk to people living with these difficulties, you learn much more efficient ways of bringing treatments and support to them. So the study toolkit has many tools. I think we counted, we've got around 80 in there. And some of them are more traditional CBT interventions. Some are drawn from diabetes education, and some are more bespoke ones that we've developed with our collaborators with lived experience to really help intervene in the illness. Um, and part of the work in study, it was a feasibility RCT, was actually exploring which tools were used and when in treatment. And I think that will help us, that demonstrates how this can be a highly personalized treatment that really intervenes at the level at which the individual needs it. This was a multidisciplinary and interdisciplinary project. So we had not only academics, clinicians, but we also worked with an industry collaborator because they helped us to develop an app through which the tools could be shared in treatment sessions. I think this was a real opportunity. And then when we're thinking about implementation science work, I think that's a really key thing to keep in mind that it seems to work better when you've got this network around you and people bringing different skills together, but also thinking about upskilling. So I, as a clinical psychologist, was learning more about diabetes, and my partner, my peer supervision partner, was a diabetes nurse specialist learning more about CBT. So we were able to do lots of capacity building there and upskilling and generating training materials to help others learn about how to work with people with this really complex comorbidity. This work has contributed to the psychological therapy that's been delivered in the first NHS England pilot pathway for TIDE. And we've written about this across several articles and explained the sort of work that was required to get this treatment to patients quickly. I think that's really necessary in this group because it is a group with untreated eating disorders, and we know that the duration of untreated eating disorder is very problematic and causes people to have this longer term illness and long lasting illness. The other thing I learned about this work was that it allowed us to really talk to people in depth, living with TIDE, and conduct clinical interviews. And that helped us to much better map what the clinical phenotypes of the illness are. And that may sound obvious, but because it's an eating disorder that's only more recently talked about, it doesn't actually have its own um, personal spot in the DSM or the ICD-10. The variants of this disorder had not previously been very well understood. And so we were able to do this really detailed work that actually describes the nature of the problem. And I think, again, that's another really good way of doing implementation work. Once you're able to give things names and describe them clearly, and do that in a way, do that through using the subjective lived experience of people that have experienced these difficulties, then you've got a real pathway to change. There were also a number of barriers. These sorts of integrated care models where you've got physical and mental health coming together, albeit that's what our patient participants had asked us to do, and not be split off with diabetes on one side and eating disorders on the other. It was a challenging job. We really needed support from local teams to implement this approach. And I think that the experience of that really varied across the country. We were recruiting throughout the UK, and some areas were much better resourced than others. We also learnt that training and expertise are quite costly to scale up. So, in thinking about the next steps for Steady, wanting to scale up the RCT and bring this treatment to more people, as a pathway to getting it into treatment as usual, we've really had to think carefully and cleverly about, do we want diabetes specialist nurses coming out of their NHS jobs for months to train in CBT? Might there be a more efficient way of doing that? And then the key barrier really has been struggling to get a funder to allow us to scale this up. We've tried 3 times, and we will not give up. But really, the pathway to implementation here is to get this into treat is to get this to get steady into care as usual, is to really demonstrate with a bigger RCT that it works and it's safe and it's benefiting patients. So while we've been able to do that through the pilot NHS England pilot pathway to a degree, we've got this funding barrier that's stopping us getting it to more people. So here's my case example two. So this is a project called Collaborative Care in Eating Disorders. It's part of a wider study called Triangle, which brings together um, participants with lived experience of eating disorders, experienced carers, and experienced healthcare professionals in a triangle to try and work together to get people having good transitions out of hospital back to the community and preventing readmissions. This project, we were able to get a bit of extra funding from the NIHR to do some experience-based co-design work to think about the longevity of the resources that we developed through Triangle. So these self-care resources are little videos, podcast episodes, written guides, all written with people with lived experience or produced by people with lived experience of eating disorders, particularly in this case, those living or those accessing care on inpatient wards, largely with the eating disorder called anorexia nervosa. So this work was to think about how we can scale up these resources and make them more accessible, more inclusive, and more diverse in terms of the groups that they can benefit. Um, And so we worked across a number of workshops with people with lived experience, carers, and also healthcare professionals to answer a research question around how can we make these tools that people can be using on their own in the community more inclusive and accessible. And how could they appeal to a more diverse group of eating disorders? Because they were quite focused on people with more of a restricting anorexia nervosa. So I wanted to share some of the themes and some of the learning from this work. People wanted authentic and inclusive materials. They wanted diverse voices and stories, and they wanted these to reflect the comorbidities that these young people live with, and to signal what they called psychological safety. They wanted them to be personalizable, and they also wanted them to be psychosocially relevant. So, talking about some of the structural and social factors they were living with in their communities. There were ideas around how they could use technology to support recovery, how they might be able to exist safely on social media and not to cue and evoke their eating disorder difficulties, how to live in a world with the thin ideal is valued. And I think this is actually even more pertinent now in the context of the GLP-1s, and how to access barriers around, how to navigate barriers around care. So this led to the generation of some new self-care tools, and I'm sharing one of these on the screen here. That was actually then produced by one of my students with lived experience of eating disorders, and an experienced carer. And we actually evaluated this as part of a student's undergraduate research project. It's bulimia in the brain. So it's trying to speak to young people about what the experience of bulimia nervosa might do to the brain, and how healing the relationship with food and the body can lead to being able to use your brain better, connect with others, and open up access to a bigger life. And I think this is one of the few that I've seen, or perhaps the only one, the only tool I've seen aimed at members of the community, um, uh, that have really targets these areas. And we've been able to take this to some private eating disorder outpatient clinics to get more feedback. And we were really fortunate that one of them's actually integrated it into their psychoeducation therapy groups. And they've been using it over the last few years. And they've shared some feedback with us. They've said that patients like the resource, it helps them to feel understood. And I think that's because it's written by somebody that's experienced the illness, and particularly for a young person. They liked how it reflected authentic voices. And several patients described the tool as the first time I felt like someone really got what I was going through. And I think that, that connection with somebody and understanding their difficulties is a really good way of influencing practice, because they might then ask other people, they might share this tool with others, and it allows them to use their therapeutic space differently. I think that's what this example's sharing. For clinicians, the zine has enriched psychoeducational content. So it's added to their practice, it's given an extra dimension and an extra element to it. Another example of this was a British Psychological Society toolkit for teachers. Um, One of my colleagues, actually, who's in the audience, put me in touch with their contact at the BPS, and they were asking for an update of a toolkit to help teachers better understand and make sense of eating disorders. So, as I always do in my work, I reached out to somebody in my network with lived experience of eating disorders and asked if they'd like to write it with me. And they're actually an artist, so they produced some beautiful images, and I'm sharing them this on the screen for you, um, where we were trying to depict We're trying to bring to life some of the ideas. So, as you can see here, we've got a list of kind of quick hits. What are the myths? And then what are the facts? To really quickly help skill up teachers in their busy working lives to help them make sense of these really quite puzzling illnesses. I think I'll go straight to the barriers actually here because I think it relates a bit more to this toolkit. I think one of the barriers here is that dissemination doesn't equal implementation. So this toolkit's been made available to all UK secondary schools, but we don't know how many teachers have changed their practice as a result of it. And that's something that we're trying to follow up and to speak to schools and to get feedback from teachers to give examples of ways that it might have changed or benefited or somehow impacted their practice as usual. Um, the other aspect, really, in terms of barriers that I've learned from this work is when you've got all these self-care tools, then you want to reach out to the community and make them available and generate more tools with the community. Funding models generally don't allow for longevity of resources. So it's unlikely, well, it's difficult to convince a funder to keep paying for a website beyond the scope of the project. And that's something that is a barrier we've come up against about where we host these resources, how we make them accessible in the long term. Um, and that's something we're working on. Also, digital resources may not reach all groups equally. The vast majority of people have access to smartphones, but they may or may not be presented in the way that a person can interact with them. They may not be as accessible as we'd like them to be, and that's another thing we need to work on. However, there are lots of opportunities here. If we create self-care tools with people that experience these difficulties and disseminate them to the wider community, we can impact lots of people at scale with quite minimal cost. Most people with eating disorders aren't in services, they aren't accessing care. Most people with eating disorders living in minoritized community groups never get any form of formal treatment. So, this is a really important way of supporting and improving these gaps in these inequalities in healthcare access because they're led they're guided, they can be guided self-care, but they're led by the patient, the person with the symptoms or a carer. um, we don't need to take years training people up. They're written for those that might need them and they can be accessed quite easily. And they can continue to be adapted and evolve. And I think, when we were doing those workshops, people were talking about policies like calories on the menu and how do I navigate this with my eating disorder, or, technological innovations like having apps, takeaway delivery apps, and how that interacts with my access to food to binge on, and how do I work with that. And we're continuing to get more topics around this that people are sharing with us. I mentioned the kind of GLP-1 medications being a particularly interesting in that area. So thanks ever so much. Look forward to discussing this further with you. That's my email if you ever want to get in touch. And thank you very much.
Thank you, Amy. Yeah, they were really nice examples of thinking about how yeah, thinking about implementation throughout the research process, which is great. So, unless anyone has some quick kind of clarifying points, I think what we'll do is we'll go straight on to the next talk now, and at the end, we will take questions from on both talks. Uh, don't see any hands up. So, our next speaker is Professor Jane Hurry. So, Jane is Emeritus Professor of Psychology in the Department of Psychology and Human Development. Jane has two core areas of research interest. One relates to literacy development, and the other, which she's going to talk about more today, relates to adolescent development and mental health, with a particular focus on the intersection between behavioral disorders and education. So specifically today, Jane is going to talk to us about implementing wellbeing and mental health action in secondary schools. So over to you, Jane.
Hi, everybody. Thanks very much, Amy, for that great talk about your interests. And I'm just trying to now find, of course, my slides to share. And I can see we've got quite a lot of overlapping of ideas there. Okay, I'm going to now share my screen. Ooh, and let's see if we can do that. Great. Um, Okay, so oh near, of course I'm not in the right place now. Here we go. Whoops. There we go. Here we go. Here we go. Okay, here we go. So, um, so Amy's talking about a more clinical settings for implementation, and I'm going to be talking about educational settings. But I can see already that there's quite a lot of issues that we share. I'm presuming everybody can hear me and everybody can see the slides. Yeah.
Yes, all good.
Yes.
Thanks, Jane.
Okay, brilliant. Okay. And I'm going to talk to you about implementing well-being mental health actions in secondary schools. So the, there's more research actually in primary schools, and it's easier to implement stuff to do with mental health in primary schools. But arguably, secondary schools are a very good place to have a look at because that's when kids start to develop their mental health issues. Uh, so I make no apologies for working in secondary schools, and there it's a tougher environment because people are more focused, teachers are more focused, schools are more focused on doubling down on the academic side. Okay, now the first thing we might ask is, given that the primary function of schools is to educate, why should schools address students' mental health well-being? Now, uh, oh, sorry. Now, I mean that as a question. So I'd quite like to hear from folks about why you think we should address well-being or mental health in secondary schools. Go on.
I'm happy to have a go, Jane. That's okay.
Yeah, great.
Yeah, I think that the two are likely to correlate, whereby if a child or student is comfortable and well within themselves, that they're more able and ready to engage with the academic material. That's just one. I've got more, but that would be one of the
Yeah,
arguments.
no, great. Yes. I think that's really important because it captures the fact that schools are a very, they're a critical place for kids growing up. Anybody want to say, well, why are we doing it in schools?
It's also a place where students spend a huge amount of their time, right? So it's a great opportunity.
Absolutely. Okay, so I mean, in fact, oops, I'm going to do this sharing business again. I'm stopping sharing and starting sharing. It always confuses me. Right.
We've got a
Um,
comment in the chat too, Jane. Prepare children for adulthood. There's a couple coming up in the chat.
oh, great. Oh, great. Tell me the
Do you
chat
want me
because I'm
to do you
very
want me to
bad.
read them? Yeah.
Yeah.
Yeah. Yeah, prepare children for adulthood. And there's another one. It's probably the only place where universal interventions can take place. Health systems are supporting people who already have significant difficulties.
Absolutely. Okay, great. Now, so I think, oh, now I've somehow, okay, hang on a minute. I can't see my share screening now. A minute. Okay. Sorry, technology drives me nuts. I'm not doing, I'm going to, right, uh, sorry, okay. Um, right, are you seeing my slides now, folks?
No, we're still seeing the Zoom window, Jane.
Okay, hang on a
Yeah.
minute. Let's try again. Uh, sorry, I don't know what's happening here. Uh, my apologies, folks. I don't know why this is doing
Did
this.
you want, I could share them from my. laptop
Yeah, that
if
would
you
be
want
good.
to share, and
So my
you'll
apologies. I don't know why it's doing that now.
you'll have to tell me when to click through.
Yeah. Okay, I'm going to stop sharing and you do. Yeah, great. Apologies, guys. Okay, now click through one. Uh, yeah, I click through. Yeah, good.
Yeah.
Okay, so yeah, stick with that. So these are some I prepared earlier. So you've given some stuff about why you think that we should take action in schools, which of course I agree with. And the, Matt's comment was about they spend a lot of time there and you can get access to them. Sort of, it dealt with bullets 1 and 2, so we get universal access to young people, and some people are keen on going to schools to deal with mental health because that's a place to get access to them, and there's good evidence that social emotional learning interventions can improve relevant student competencies. But as you also say, schools are also a key environment where kids spend a lot of time, and it's critical to their development. And I was thinking of that when Amy's talking about eating disorders. You know, that a kid with eating disorders is likely not going to be able to do as well academically or socially as they might need to do, and that can have long-lasting effects. I've also worked with kids that self-harm. They often leave school without qualifications. Kids who are youth offenders, similar. So we need to get the environment right for the kids so that they can do what they need to do during that space. Now, I've highlighted student competencies, or bolded student competencies, which is one area that interventions for mental health focus on in schools, and the other area is the environment, which I've bolded in the second statement. Now, the evidence of effectiveness of whole school approaches is much weaker than that for the student competencies interventions. Okay, skip to the next slide, please, Matt. Now, schools are doing stuff. So these figures at the top of that slide are taken from Children's Commissioner's recent census of school actions in mental health. 97% of secondary schools do provide SEL interventions, social emotional learning. 82% of a school mental health counsellor. 64% of an educational mental health practitioner. They must have designated safeguarding leads, SENCOs. They must maintain behaviour policies addressing bullying. They're encouraged to appoint senior health leads in their schools. Okay, flick over, next one. So they're doing stuff, but little is known about what in practice, which students benefit or how consistently actions are implemented. And there really is very little information about what schools are actually doing. And, you know, Amy, I was listening to you saying you would like to find out what they're doing in the schools. Yeah, we need to know more about that. Earlier work that I've been able to find out about in way back in 2013, Vostanis and Co. in Britain did a survey, and they talked about schools relying on locally developed rather than evidence-based approaches. But it's quite old, that information, and there's some information from Moore and Co. in 2017 also suggesting similar kinds of stuff, but there's very little information. Right, flick to the next slide, please. So I'm going to situate some of this, my ideas and opinions, within the basis of a project I've been involved with called Restar, a 4-year project. It was it was specifically looking at the reduction of depression in autistic and ADHD teens, and I was always looking at kids in mainstream school. I've given the hypotheses here because, again, in a sense, they reflect these two sort of my big pointers, one looking at student competencies and taking what you might call a medical model, and another looking at environmental factors, which is taking more of a social model. So this project mirrored that approach. They started off with a more medical model. Autism and ADHD are related to emotion regulation issues, and the emotion regulation issues are related to depression. And so let's work on the mechanism of emotion regulation. That was what we intended to do to begin with. But the hypothesis was revised. Again, we were doing the same sort of thing that Amy's talking about. We talked to a lot of young people who are autistic or have ADHD, and they were really saying, well, no, actually, there's a lot of trouble with the environment, and in the literature, same thing. Schools are seen as quite stressful places for these kids. And then we flicked to I hope you're hearing me. I've got a low bandwidth. To a more person environment fit model of leading to depression, which is something that I guess as psychologists a lot should be familiar with. Okay, flick to the next slide. So my particular interest was that mental health professionals are the ones that design most of the school interventions. And students, particularly atypical students and teacher voice, are underrepresented. This is a problem because school staff understand better than mental health professionals what the fit is for schools, and their buy-in is important. It predicts good implementation. And the students, again, similar to what Amy was saying, they can articulate what they need, they can illustrate it better, and it's not always the same as the stuff that the mental health professionals might think of. Okay, click to the next slide, please. So we did a survey, there's a range of things that we started, and you could pick that up from the website I gave you in an earlier slide. We surveyed 101 school staff with pastoral responsibilities, so heads of year or designated mental health leads, that kind of thing, in 72 schools, and 109 11 to 16-year-old mainstream students diagnosed with autism and ADHD. And they rated 39 items on school action to reduce the negative emotional experiences of autistic ADHD students and staff working with them, on how important they thought these items were and whether or not they were implemented. We'd done a whole process before to try and make sure that we got the key items, the key school actions. And we had some open questions as well. And the staff also rated enablers and barriers. Okay, flip to the next slide, please. Oh, this is all right. Just, I think, flick over this. Just flick very quickly through it, Matt. This is an example of the sorts of statements that we had and examples we had in the survey. It's just to give you an idea. It was quite a lot of information that they got before they rated. Okay, flick to the next slide, please. Okay, here we've got, so we took all these 39 items for whether rated by importance on a 1 to 5 and rated on implementation. And we grouped them into 5 groups, themes. Whole school actions, positive approaches and agency for the young person, trust, belonging and understanding, staff relations and training, and emotion regulation interventions. So we grouped them into these themes. And one thing I want to show you on this slide which is showing you the responses of the staff and the students, was that there wasn't really any significant difference, certainly in importance across the piece, in terms of the actions that staff and students thought were important. So the point about that is that there's a mix up here between staff, the student competency stuff and environmental stuff. And both staff and students thought both were important, and there was no significant differences. There was a significant difference in implementation between whole school action and emotion regulation interventions. They were more likely to implement the emotion regulation interventions than whole school approaches. That was, and the other thing you might notice here is that the bars for the students are always lower than the bars for the staff. So they tended to think these items were less important, and they tended to think they were less implemented. Okay, flicks to the next slide, please. Those differences were significant. So staff ratings on implementation were strongly associated with how important they thought those actions were. And student ratings on implementation were not associated with their ratings of importance. So the staff are in control, as we might expect, in terms of what happens in the schools. Flick to the next slide, please. So here are some items that both staff and students thought were critical. They were important, but they were also being implemented. Now, I'll just pick up on the bottom right-hand corner, the emotion regulation interventions for atypical students. Well, they were in this case for kids with autism and ADHD. Now, both staff and students said these were high on the number on the type of actions that the school implemented, but students didn't really like the interventions, or a lot of them didn't really. They weren't very keen on the interventions that were specifically for neurodiverse students. Staff had rated them the most important, fourth in importance of actions in school, whereas students had rated them down the bottom end, 30th out of 39 for importance. And in our talk with students, because we did interviews and so forth, the key thing that they found difficult about these specialized interventions, so probably delivered in groups, is that they were they didn't take account of individual differences. They were a bit inflexible. Okay, skip to the next one, please. Okay, we'll just bang it through so as we've got the whole of the slide. Thank you very much. No, back up again. Sorry. Okay, addressing bullying was very important for both teachers and students, and that's good news in a way, because there's strong evidence of the effectiveness of anti-bullying actions, evidence-based ones in schools. However, interestingly, the teachers and students did not agree about implementation. The teachers thought that they were doing a good job at implementation in terms of bullying. It was rated the third most commonly implemented thing, whereas the students were saying, nah, it wasn't really so well implemented. So this is a point about you're getting different sides from different groups of people. Click to the next one, please. Okay. Students did say that they were getting a lot of support and that most of it was helpful. Well, they were getting some support. And the things that they rated as helpful were strategies with managing their emotions. That was always seen as helpful. And this is in the open comments that they described what they were experiencing. And so these relate more to student competencies. They like personalized support, but that wasn't always, that could have been a one-to-one with a counsellor, but it was often much more just a teacher taking, or anybody of Senko checking in with them at the beginning of the day, or that kind of thing. Those kind of noticing things they found very helpful. They also liked teachers. Teachers were helpful. Always they said that the ones that commented on teachers being helpful always said they were helpful, but they weren't not all the teachers were helpful. So they would say some were great, but others didn't get me. There's one other bullet, I think, down there, which was about, can you just see if there's another? Yeah. Only 4 mentioned named interventions. And they were mixed. So 2 were keen on them and 2 were very unkeen. Okay, flick to the next. Again, it was the same thing, that they didn't like one-size-fits-all stuff. Yeah, just go through this. That's brilliant. Now, the teachers were asked if they delivered any interventions to support their students with emotion in the last 2 years. And over half of them said they had adopted existing interventions. All of the interventions focused on student competencies. They were typically based on books or materials available online. They were not evaluated in peer journals. So the most common was zones of regulation, for example. A third got help from mental health support teams or local authorities. A third got some support, and a third got little support. Right, next slide, please. We're nearing the end, guys. Enablers and barriers. Nothing new here. just what other people have found about implementation. Leadership, training, applicability for all students are enablers. Lack of staffing, lack of time, lack of resources, and lack of support from external agencies are barriers. Click on to the next one, please. Right, so I'm now going to the points I picked up from our work in terms of implementation, that adapting environment and supporting student competencies are both important. Teachers and students didn't always agree, so probably we need to hear from both parties when we're working in schools implementing stuff. And their ideas were not necessarily well aligned with mental health researchers, who tend to focus on student competencies and evidence-based intervention. I've blethered a lot. This is a big point for me. And the last one, resource limitations support nudges. I'm not sure if that's right, but the problem is that we've got to take account of the fact that there's a limited amount of resource in schools. Click to the next slide. This is the final slide. So these are drawn more generally from the literature about implementation. There's a big gap between evidenced interventions and school practice. I mean, an enormous gap that we really need to think about seriously. How do we resolve the conflict between structured, tested interventions delivered with fidelity and interventions which fit schools and students? So this is a problematic question about our research methodologies. Achieving a fit between intervention and school, like, some of the stuff Amy was talking about resonates with us. There is a model of that in the Learning Together intervention. There's a book by Chris Bonnell, Toxic Education, which talks about this as well. Good read. So we've got to get a fit if we want to implement well. Flexibility of intervention, which I'm implying we probably need to do, implies monitoring by schools. So if you've got flexibility and you don't monitor, you're going to get not very good outcomes. Evaluation of SEAL, which was a program some of you might remember, promoted by the government, it didn't get evaluated well because everybody was doing it very differently. And how do we ensure schools know about evidence-based interventions? So our panel of experts told us that the reason that people weren't implementing stuff in schools because they didn't know about it. There we go, that's it. Let's see what you all think about these things. Can you answer all these questions?
Thank you, Jane. Yeah, another great talk. Yeah, it's really nice just to see some research that really looks at what goes on inside schools and how complex these settings are. I think that, yeah, both settings, what Amy talked about and you, that really complex settings that we need to think about all of these different processes when we're implementing interventions. Okay, yeah, so Jane posed some questions there. And yeah, so we're going to open it up now to questions for either Jane or Amy. I can see, have we got any questions? So feel free to put questions in the chat. Andy, you've got to go. Do you want to ask a question before you go? Yeah, or raise your hand and we'll go through questions one by one. Over to you. Daisy.
Hello. Oh, sorry, I'm turning my camera on. Hi, Jane. I have a question for you. I am really interested by the increase in mental health support teams and designated mental health people to schools. And I know the government is trying to roll that out more. I just wondered whether in the research you're doing, whether you're seeing that means schools are becoming a bit more aware of more evidence-based programs in schools, or whether we know how that rollout is working and influencing practice. Sorry, two questions there.
Hey, okay. Well, first of all, I couldn't say that the rollout is, how quickly it's been moving, because of course it started in, what was it, 2018, with the Green Paper at that time. But I would say to you that my answer to the second question, does it make a difference to whether they're implementing evidence-based interventions? Well, from our survey, it doesn't. There wasn't one school that mentioned an intervention that had actually been tested to our, standards, if you like. I'm not saying ours are right. I mean, the most commonly used was zones of regulation. That was the most commonly mentioned one. And it's a problem with that one because it's actually made for primary schools and it's a secondary school. So the short answer to you is, I mean, I think this is a huge problem and we've been ignoring it for decades, and we better get a grip. We're talking to ourselves. The research community is talking to itself. So if you're talking about implementation.
And Jane, do you know whether people are doing research with the mental health leads in terms of how well skilled they are and what they then do in terms of sharing practice in schools?
I don't know the answer to that. And I know that people had, obviously, in our survey, they valued mental health support teams. About a third of them really valued them. And some of our panels were saying that they were good. So I think they are good. And they're working together. Yes. So, but I don't know any more about it than that.
Brilliant. Thank you so much.
Any other questions? Again, either in the chat or raise your hand. I've got one then while we wait for other hands to go up. So Jane, it's about your hypotheses. So you had two, your original hypothesis and then the second one, which was more about the person-environment fit. Yeah, so as I looked at that, probably because I'm an emotion regulation researcher, I didn't like how the emotion regulation disappeared from the second hypothesis. Now, I wondered if it could almost be a combination, right? So that I think that person-environment fit is clearly important. But wouldn't that lead to, that's very likely to lead, if it was a bad fit, for example, to more emotionally challenging situations and perhaps more intense emotions being experienced, which would then lead on to emotion regulation difficulties, onto mental health.
I mean, maybe my shorthand of that little arrow or two misled you into thinking that they ignored emotion regulation. They didn't. So it was more shifting it to a notion that both regulating your emotions and regulating the environment are important. So there was an early part of the survey, which has been of the project, which has been published, showed that kids with autism and ADHD did have greater problems of regulating their own emotions than their typical developing peers. But they also experienced greater problems in the environment than their typically developing peers. So, they had more issues about being bullied and that kind of thing. So it's that combination of the fact that you might have difficulties, but also, the environment interacts with your difficulties, if you like, to magnify the problem. Does that help you at all, or?
Yes, no, that makes sense. Yeah, that was kind of along the lines that I was thinking how they would almost, a combination of those two. Do you find similar, Amy, with the population use study in terms of those?
Yeah, so we do have a lot of data on autism and eating disorders because the comorbidities, probably around 30% of people may have ASD or traits or autism traits. I think all of the data point to more emotional difficulties, more social difficulties and challenges in those that have autism as well. I suppose on that point, I really wanted to ask you a question, Jane. Actually, I think you sort of talked about the adapting some of these interventions for people with autism. And you said that the people with, I think I understood it correctly, that you were saying that autistic people weren't really liking it. And that the reason I'm asking you the question is that in the field of eating disorders, we do have some prevention programs, and there's some work under the way at the moment, which is about how to make these more effective and considering things like neurodivergence. And some of the feedback's been, do we kind of go and adapt existing things and just make them more neuroaffirming and more relevant? Or do people need something separate? But then it is teachers delivering these interventions. So they may or may not know whether students in the class are autistic. And then do they need to do one version for the autistic children, one version for the others? It seems a bit strange. I was just wondering if you could share any expertise around that.
Well, so to clarify what I was getting at with the kids not necessarily having mixed views about specialized intervention. Um, I mean, it could have really hit the spot for some of them, but not for
Yeah,
others. And what they didn't like was, they talked about, oh, I was told to go and do this rock carving, and it was a completely, had no meaning to me. So it was more the idea that there would be a stereotypic view of what you do for a kid that's got this diagnosis,
yes,
and it didn't necessarily fit for them. That was really what they were saying. So it was more, I mean, very it kind of fitted with what you were talking about things needing to be individualized, if you like,
yeah,
for a particular kid. But that would obviously be if you were doing a one-to-one, or if you were doing a group, you'd have to be sensitive to the fact that the kids in the group might be heterogeneous. I suppose in terms of the universal interventions, so things that we're just trying to help everybody with their emotion regulation in this case, really,
yeah,
there was more embracing of that kind of thing. Funny enough, I don't know, maybe it's not so that people don't feel sort of singled out so much, and they
mm,
did like being helped with managing their emotions. They found that helpful. So I think those generalized interventions where they seem to land for. Uh, uh, According to the ratings and the comments of our young people. Does
and
that
perhaps,
answer the
yeah,
question?
that's really helpful. And perhaps teachers are more likely to then draw on those if they've even heard of them, because they see them of there's sort of a face validity to it, isn't there? That this is something that helps everyone. Let's give it a
Sure.
go.
And there's
Mm.
quite a lot. There's a bit of research which suggests that the sorts of things that you do for kids with special needs, special educational needs, are actually just the same sorts of things as you do. They're good for everybody.
Yeah.
I mean, yeah. One of the big things that I feel about what came out of our work, and other people have said the same, is there's a lot of stuff about pedagogy. Positive pedagogies that is good for everybody, but it's good for these kids. Yeah, and that's where the environment thing might come in, that they tend to
Mm.
get told off more, get detentions more, and so forth. And so, if you have a school practice where these things are managed a bit more positively, if you like, that's good for everybody.
Someone in the chat's actually asking about implementations. Yeah, thanks, Maria. Implementations regarding ADHD and ASD at school. Maria's saying, I understand that a lot of children go undiagnosed because their behaviours are just labelled as so-called difficult without further investigation. So, in encouraging school staff to use evidence-based interventions, are we teaching them about ASD and ADHD traits, or just working with those with established diagnoses?
Well, I saw that. Thank you, Maria. There's 2 points I would pick up there. First thing about the training side is yes, both teachers and our students wanted more training on the specificity of ADHD or autism. So that seems to be, and by the way, the stuff that you were talking about, Amy, about using the voices of
Yeah.
people who have lived experience. We very much found that was a powerful way. I mean, there's so much I could say, but we didn't have time to say. So I think that, we've got a lot to learn about that. But the other point that Maria's pointing out about kids that are undiagnosed, well, that was something that teachers really talked about. And again, it relates to school policies, because what they said was they could see that a kid was struggling, but they didn't have a diagnosis. And you can't get a diagnosis, or, it's very hard. You've got to wait years for that. They didn't have a diagnosis, and the behavior policies forbade the teacher from making some allowances that the teacher would want to make, but they couldn't make because of the behavior policy. So I think they were articulating the fact that sometimes the teachers weren't being given enough autonomy to make their own judgments.
Thanks, Maria. Any other questions from anybody there? We've got
Harriet sent one, yeah.
Yep, another one from Harriet, yeah. Question for Jane. I was wondering whether neurodivergent young people had anything to say about intervention delivery, particularly in school contexts, in addition to content.
Well, I can't answer that directly because I don't have that data, Harriet. Because we had a survey, we had to keep it brief, otherwise nobody would have answered it. And they gave some short responses, so we didn't get that kind of level of detail that would allow me to give you an answer exactly. But I think, well, what I might say is related is that students talked in our interviews as well about the difference between one person and another in terms of their interactions. So, a counsellor might be very different, that they might get them or they might not get them. A teacher might. So it speaks to the delivery side of things, that they saw. What was very important to the young people was that somebody could hear them and respond to them, not be lacking in empathy, if you like.
So is that that personal connection, personal interactions, perhaps in terms of delivery. Yeah, how
Which
about
would
you,
relate
Amy?
to the training thing as well. Obviously, if the teachers were a bit more, they understood a little bit more why a student acted in a certain way, then they would be more empathetic. Hearing the voices of the young people helps empathy across the piece.
Yeah, it's an interesting question, right? In terms of, because we quite often just think about adapting content for different populations, but actually adapting the delivery style, how the intervention's delivered for different populations is also quite likely very important.
And we know that delivery is strongly related to effectiveness of intervention anyway.
Yeah, and giving options, because I think you may hear it differently from one person compared to another, from a written version compared to maybe a video. Different people will take in information better in different ways, and I think giving options can be really helpful. Yeah.
I think it also has implications for teacher training. So, my view, if you're asking me about mental health intervention in school and implementation, is that we need to take it much more into the mainstream of education, because we're not, educationists aren't mental health specialists. We've got to think about what we can do in using the stuff that educationists do. And that would involve also teacher training.
Yeah, and they already, there's already lots going on in schools, right? It's just different. Yeah.
Yeah. It might be good, you see. I don't know if I'm saying, oh, they were using this or that, or the next thing they're not evidence-based. I'm not trying to say that they didn't work. We didn't know that, but my big point was that, the researchers are working away, and then they're asking us on a catalyst seminar what helps with implementation. And I'm kind of saying, can you wake up and smell the coffee? It's not happening in schools, mate.
Jane, what's stopping them from using evidence-based interventions? Is it sort of knowledge of them, or people just get stuck in habits, or are
I
these
think
interventions too costly for schools to buy in?
I think all of the above. I mean, one
Yeah.
thing that we said schools won't know about a lot of these things. That's the first thing that they won't know,
Mm.
and they said that to us. And the training that you need to do them is often not available. You know, how would you get it? There's no money. So the resources are a huge barrier to certain kinds of programs. But I think, yeah, knowledge probably a big one too.
Maybe confidence, if you're used to delivering something and you're familiar with it, you kind of carry on. Whereas, you'd have to then learn a new module, wouldn't you? And you're a busy teacher with many, many jobs to do. It has lots of parallels actually with upskilling um, colleagues working in physical health settings with therapeutic skills, more kind of psychological therapy skills,
Mm.
which can be beneficial because we know mental and physical health go together. But then the question is, how do you access this group? How do you sort of take them out of their normal work, upskill them, build that capacity, roll it out at scale? And that's something where we've learned from the study project, how perhaps we have to adjust our expectations about to what level people will be trained. Maybe a lower level with some supervision is better because it's faster and it can reach more people. Um, and then perhaps more severe cases need to be referred on.
I mean, the learning together model that was implemented successfully in English schools by Bunnell, Viner, and various other boards. Um, uh, they have a model of having a school panel which recruited kids as well as teachers and made sure that the kids represented the full raft of students rather than just the ones that usually get picked, that kind of thing. So there are kind of models for how you could negotiate in school, trying to support what's going on. Um,
Mm.
I mean, I think there are. I suppose I think there are things that can be done. I think the positive pedagogies, um, listening to students and teachers as a regular thing, and monitoring things. Um, those would be good. But the stuff about sharing information from research, that's another big issue.
Daisy.
Jane, I just wanted to follow up in terms of some of those whole school approaches to mental health about your view on or your knowledge of the research in the PSHE curriculum space. Because I think this is where a lot of schools sort of obviously cover mental health and well-being issues. And I think quite a lot of the PSHE curriculums are off the shelf, and there's a sort of assumption that there is evidence underpinning them. And I just wondered whether you had any thoughts in relation to PSHE spaces and their whole school delivery.
Well, I mean, I don't know if I've got any particular insights, Daisy. I mean, it's obviously the slot where people who've got mental health interventions are going to try and pop their intervention. It's going to be in PHSE. Uh, I mean, and then all of the stuff that we've been talking about, the fact that teachers aren't necessarily well suited to using the methods that are, they're not well trained to use or not comfortable with using some of the methods that some people might ask for, getting to know the materials and all those kind of things. I mean, it's useful to have that slot there, but how we use it, maybe we need to get more organized nationally about how we use it. I don't know.
Yes, because I know there's all sorts of different curriculums out there and schools use them in different ways. Thank you.
Well,
And kind of finding out about what the students think of those slots, what's already delivered there, right? And whether that works, and all quite valuable. We uh,
It
did
sort of
some,
sounds like there needs to be like a nice guidelines for schools. because I suppose at least in the health context,
Mm.
we have clinical guidelines to draw on about what's recommended for a particular so-called disorder, whereas it sounds like schools might be sort of searching in the dark in a way.
Yeah, true. I mean, the access to the information might not be as easy. I think, Jane, you mentioned in one of our IOE mental health talks, or some another project you did that where you tried to find out where they got the information from, and it was mostly from books. I think you said something like if someone writes a book about an intervention, then the schools are more likely to use it.
Well, it's the same project. I mean, we got the teachers to write down the things that were actually being implemented in their schools, and then I looked
Mm.
up all the things that they mentioned, and they were all the ones that were they named quite a lot of interventions, and they were all ones that were available online or had a book, and none of them had been evaluated in effectiveness of the kids, in the research literature.
Mm.
So it was that's where we got this idea that teachers seem to be, well, it makes sense. They're reaching out to get something that you can just consume quite easily and use in school.
Yeah.
They're not going to look at a research paper, you know.
No. All right. I think we're about at time now. So thank you both for yeah, really interesting talks and discussions afterwards. Yeah. So yeah, lots of work still to be done on implementation in all these settings, but it's yeah, really, really helpful to hear these kind of insightful studies that are moving us forward. So thank you. And thank you to everybody for coming. So that, as I said, that's the final Catalyst seminar for this academic year. But yeah, if you haven't signed up, sign up on the Catalyst website and you'll get information about when the next slot starts next term.
Thanks very
Thanks,
much. Bye.
everyone. Bye bye.